There we go. And actually, I was asked to talk about investment, but a lot of our investment at NIHR is England only, so I'm not going to do that. You'll get a bit of that, but actually we're here for the whole of the UK, aren't we? So let's actually think about the whole theme and how all of us, whatever country we're in, can actually think about any investment opportunities there are and how we can use those to address research inequities. And I am going to come up with that underserved word in a minute, so hey-ho, we'll come to that in just a moment. But from an NIHR perspective, it's really important to acknowledge that one of the operational priorities is about bringing clinical and applied research to underserved regions and communities with major health needs. And we'll come to that word in just a moment. But that whole idea of access to research is really important. We think about health inequalities, we think about the impact that has on all sorts of things like disease prevalence, the conditions people live in, the access to services. But one thing we often don't talk about is that it's about access to research as well. And that is our responsibility collectively. And that access to research gets played out not only in actually participating in studies, but it's actually in informing what those research questions are going to be and making sure that we're doing the research that matters to the people that whose lives we're trying to improve. And that is so, so important. It's also about the things that we've heard about already first thing this morning, about encouraging others, that you need to get to the key people in order to break through. And of course, we do use the term underserved, I'm afraid, because what it means is if we are underserving, it's our problem and it's our fault. One of the issues with that phrase underrepresented is there was something about people not coming forward, whereas actually, I think for all of us in the room, it's about us making sure we go out and realising. And absolutely, I have heard before about the kind of misinterpretation of that word, but it is important for professionals in particular to think about underserved, because that lays it back with us, doesn't it? And there are lots of ways of thinking about what that actually means, and it is very much, as we've already heard, context specific. And it is about actually relative to the things that Saul was talking about literally just now, that what your population is like and what's your recruitment like relative to that population. Is there a big mismatch? I suspect there is. So actually, how do we think about that a bit differently? There's a great paper by Witham and colleagues that sort of represents a whole body of work that's been done. So I would recommend you go and look at that. But it is also about how interventions actually compare with across different groups, and the fact that research doesn't necessarily look at that. Sometimes, though, it's simply restrictive study eligibility. So my own background is ICU, and for years and years, I'm part of ICNARC, part of the board at ICNARC, we excluded pregnant women from all our studies in ICU just because we go, whoa, pregnant, no, can't possibly do that. Well, what do we end up with? We end up with interventions that can't be used with pregnant women. So pregnant women get a much worse deal in ICU. That is changing, and we're very grateful for that. And as people like Danny Macaulay regularly say, we've got to think about risk and how we actually can take proportionate risk with research, or nothing will change. So those things are important. But sometimes, and I think this is the bit that is our business very much so, is that the recruitment strategy is just misaligned. We're just not actually thinking carefully about how we actually recruit people. And I refer here to a paper that's published this year by Matthews and colleagues that was just looking simply at the numbers of women recruited into cardiovascular studies. And actually from their scoping review, they looked at a number of different papers, looked across some of these papers that have recruited millions of people. And of course, women are grossly underrepresented. And why? It's very simple things. It's actually they can't travel. They've got childcare responsibilities, or simply the cost. And cost is a really, really big thing, isn't it? We know increasingly now that people are saying, no, they won't be recruited into studies because they've got to pay their travel costs up front and then actually claim them back again. Well, you know, why can't we can fix that, surely to goodness. And I'm sure many of you like me have had brown envelopes with cash in them for people to say, actually, this is what you do. I've done that as a CI. And there's a few of them somewhere in somebody's office with my money in, but there we go. But I think the important part of this particular evidence is whose responsibility is this? And I would say that is the responsibility of all of us in the room. It's absolutely the responsibility of research nurses, research midwives, research practitioners. It's certainly the responsibility of CIs. And so when we think about actually what that means, the consequences of being underserved and what that means is that we've got that evidence gap. We talked about that already, didn't we, just in relation to ICU in particular. But also, we know that sometimes when we're implementing things, the reason for having process evaluations running alongside trials in the later phases is we need to know actually what really makes this work or what really stops it working, because the hard trial data won't tell you that. And we often know that an implementation will work very differently in one place than it will in another place. And so if we actually don't recruit across really diverse groups, then we never know really whether you can implement something. It might work on paper, but actually it's how you make it work is the bit that makes the difference. But also we know, don't we, that study participation offers hope. That's one of the most important things that drives us all, doesn't it? And so we need to think about that. So how do we actually pull all of those kind of burdens, if you like, that we should be feeling into some opportunities for us, particularly in research delivery? And I think there are some lessons that can be learned from that particular paper. And one of those is about recruitment strategies, looking at those recruitment strategies that we've got through an inclusion lens, not through a how can we get to that number quickly enough and how can we beat the lot down the road, because I'm very aware that some studies now you're not even getting to recruitment because suddenly the Eastern European countries have recruited and suddenly it's gone again off your radar. So there are some interesting things that are setting up slightly more competitive recruitment strategies, which is a bit of a disappointment. But actually thinking about inclusion right from that first point, thinking about the things that we heard right at the beginning about how you actually even recruit and costing that into your budget. If you're going to have to go to different places to recruit, then put that in the budget. If you say you're going to do it and it's not in the budget, then the reviewers won't believe it, will they? So this is your chance to influence actually what happens at that early stage. Really, really important. And it is also important to look at eligibility and recruitment gaps. Those data give us some great insights, don't they, into, well, all these people were eligible, so what went wrong? How did we not recruit these people? What was the difference between being eligible and actually saying yes? And is it something that we did differently, or that we could have done differently, or that we should do differently? All of those sorts of things. And sharing responsibility for this, actually how we're recruiting people from different backgrounds is all of our responsibility. And one of the ways of really getting this message out there is to write a paper about it. If you use different recruitment methods, actually just publish that, because that's a really important part of this whole research endeavour that we're engaged in. One other way of thinking about this, of course, is actually getting research delivery embedded into clinical roles in a more systematic way. St George's in London. Is there anybody from St George's here? Oh, right, brilliant. Okay, the ED at St George's in London has a great scheme with the clinical nurses where they can actually volunteer to go into a research delivery role, and they do a week doing delivery, a week back doing clinical, and they do this for a 6-month rotation, and then another group of people come through. What you end up with then is a body of clinical staff who understand research delivery. What a brilliant way to do it. And also people then who, when you're trying to recruit more people into delivery, they get it and they go, actually, I'm ready to make that change now. So it's important to be aware of the things that are already out there and actually seem to be working well. And also there's a lot more opportunities now, either through your RRDNs, your regional research delivery networks, through all parts of the infrastructure have career development opportunities built in. That is absolutely in their budgets, so they should all be advertising things. So actually thinking about access to research and offering this in a different way as a motivation for why you should get a personal award rather than somebody else. So just thinking about how you build these things in. The first of these is the bursary scheme. I'm sure you've probably already heard about this, but this is absolutely undersubscribed at the moment. So the money for bursaries is going to be given to something else if we don't get more people applying for them. And so this is a really important scheme. I'm not going to go through all the detail because that will take too long, but I would suggest if you're thinking, I want to do something else, maybe I want to dip my toe into the postgrad cert waters, then actually have a look at this, because this is a way of doing an online master's programme for free, because the bursary will pay your fees. So at the moment we are well undersubscribed with the number of bursaries that we've actually got money for. So have a think about that, or encourage your colleagues to look at that as well. As I say, we won't actually go into every part of that, but you've got the detail there when you get the slide set. The other area to think about is internships. Now, the NIHR has long funded internships, but they've been linked very clearly to the clinical academic pathway. So the idea was that over on, I don't think this has got a little doofer? Oh gosh, I've done it now. Okay, one of the things that the internships were designed for previously was to move people into those clinical or practitioner academic awards. So it's the stuff over on this side of the screen. In other words, you've got an internship as the first stage of thinking, I might do a PhD eventually. What we've now got is 3 times the number of internships, but they're for people to stay where they are. So people working clinically who actually want an internship for research that allows them to stay where they are. And they may come to you and say, actually, I think we could be doing something a bit different in my outpatients department. How can we get more people engaged in research? Or it could be for you in research delivery, saying, well, we need to think about recruitment strategies differently, because the biggest challenge in having burdens laid on your shoulders is you go, well, when have I got the time to even think about this? I know it's something we need to do, but I've got no time, no capacity. And that's what something like an internship does. It just gives you a bit of paid for time to actually work out how can we do this a bit differently. Or it may be something about linking research delivery and care delivery. And so, again, there's lots of detail on this slide about internships, but if you were thinking about one particularly from a research delivery perspective, it may be about getting a new environment ready for the delivery of studies. It may be about different recruitment methods so you can improve that diversity so that you're actually really more closely representing the populations that you're serving. And there's a number of different things in there. And some of that is actually just about opportunities for culture change, to get people to think differently. The bottom line is we want research to be everyone's business, don't we? And it's easy to say, it's much more difficult to actually achieve. And so it's thinking about what these opportunities can do for you. It's not necessarily for somebody else, it could well be for you. So have a bit of a think about those sorts of things as well. I'm just going to show you just a few examples of the sorts of things that we might fund through internships. These are already in place. Firstly, the work that Helen Oldnow has done in Ardash. Anybody from Ardash here? No? Okay, Rotherham, Doncaster, South Humber, they actually set up the first UK community research hubs. Amazing work. She won awards for it, and it's still ongoing because they keep reapplying for awards saying this is what we're doing now, and it's amazing. But that's the sort of stuff that some time out for an internship can help you to work out. How do we set this up? What do we do? What resources do we need to be able to do all of that kind of thing, and so on. And the huge impact that one thing actually did in terms of recruitment into portfolio studies and actually getting more clinical people involved in research. And Deep Sea in Lancashire, CRF, I know we've got Paul here, but so Deep Sea also was looking at increasing that reach of studies into ethnically diverse communities. And again, she's been shortlisted for awards for this work. It's made a big difference. It's changed where they came in terms of the league table of recruiters. So just showing that this actually makes a difference. I've shown this many times before, but these researchers, I've obviously got you in mind, Paul. This is Lancashire Hospitals teaching us, but such a simple idea. The research nurses and the clinical nurses coming together, putting up a board in the area where the families are waiting to go in for visiting. And part of the impact of this is they come in and they go, why isn't my dad in this trial? Because he should be, because actually you've got this going on. So lots of things going on and ideas to think about if you're not quite sure, well, how would I use an internship? in terms of the sorts of programmes that we've got going on, you're hearing in a moment from Roxanne, Professor Roxanne Crosby-Niobe. And Roxanne is our leader programme director for the Senior Research Leader programme. We've got a great balance of people working in delivery, leading in research delivery, and people in more clinical-based roles, which is fabulous, and it's exactly what we wanted. So again, you can talk to Roxanne about that if you're interested in that. But also, we're very aware our role for nursing and midwifery is we span the whole of NIHR. So while Saul was trying to name and shame me for all sorts of things that RDN are up to, I don't sit on their boards, thankfully. But actually, because we're in a very privileged position of not being anchored into one bit, it means we can influence what the academy do and various other parts. And so actually, one of the first things I did was ask how many people who are working in delivery get invited for interview if they apply for anything in the academy. And the answer was very, very few. And it's a big problem. So what are we looking at? Well, what can we do to improve people's CVs? So one of those is writing for publication. So we've been running some internships, and Naomi's helped us with some of this work, particularly around conference abstract writing and so on. So that's an important initiative, but there's a series of webinars out there that are available for anybody to go in and access. They're not limited to people who are on an internship. And I'll show you the link for that in just a moment. We've also got the PI pipeline programme, which again, with the drive of Naomi, is being developed now for franchising into Scotland, which means then, if that works, we can look at franchising it out across all your regions. So we're not going to have this crazy situation where we've got all these applications and a very small number of people actually who we can give places to. So that's important. But also getting people like yourselves involved in assessing grant feasibility as well. So as grant reviewers, and that's a great thing to put on your CV as well. But it also means then that we've got studies coming through onto the portfolio that have been assessed by somebody senior in research delivery who's answering one question: can this study be delivered? And to get that question answered at the point at which the application is being assessed for funding is a real move forward, and so important. But it also motivates people, because they go, actually, I do need to get involved in this, not just when it comes to me, when I've got to somehow shape it for HRA application and so on. So those sorts of things are important. And in particular, we're looking to target people who are underrepresented in different settings and specialties and so on. That's just a slide that tells you about those writing skills. It's on Future NHS, so anybody can get in there, set up an account, and just go into these webinars and have a look at them, because it may be that there's great work that you've got going on, that all you need is actually somebody to motivate you to say, why don't you publish this? Actually, this needs to get out there. Or why don't you develop a conference abstract? Why haven't you got a poster? So think about all of that, and hopefully those resources will help you. The PFFA I've already talked about briefly. I've got 50 seconds. So this is actually what PFFA, the Pre-Feeding Funding Feasibility Assessment, is actually all about. This absolutely is UK-wide. So any of you from the devolved nations that haven't yet got involved, come and talk to me, and I'll make sure you get onto the list and get involved in that sort of thing. Again, when you see the slides, you can see the detail of what we actually mean by pre-funding feasibility assessment. I run drop-in sessions when people are doing that reviewing, so that if they're not quite sure how to word things, or whether can I really be this cheeky about what the CI wants to do? So we run those sorts of support sessions as well. So that's all that I wanted to say. 10 seconds. You have questions? Yes, I'll stay for questions. I won't disappear.
Thank you, Ruth. You were talking about underrepresented groups, and actually it seems we have people who are feeling underrepresented in the room. So this question came through in a number of different formats, but the question is, what about the non-clinical staff development opportunities, such as the ones offered to our clinical colleagues? Are non-clinical eligible to apply?
So the latest investment, the 30 million a year for 5 years, is for nurses, midwives, AHPs, healthcare scientists and pharmacists, and for people who are in, and this is DHSC wording in regulated professions. I think I'm sure there are CRPs in the room. One of the big things we need to do for CRPs is to make you a regulated profession. And then all of a sudden, all sorts of things will be open to you. But it's actually DHSC who've said they have to be regulated. But healthcare scientists opens up a whole raft, and particularly pharmacists who've had such a raw deal in terms of research opportunities. So that's that particular pot of funding. And as I say, it depends where the money's coming from as to what it's for. Certainly the funding that comes into research infrastructure, all parts, CRFs, BRCs, the whole lot, that is up to those people to work out how they want to use all of that. So I would say it's a lot freer than it was, let's say. And we're continuing to work on that.
Thank you. I think we've got time for one more question. What recommendations do you have to address socio-economic status and its effect on patient recruitment, especially to clinical trials with demanding visits?
Yes. So some of this actually comes back to that pre-funding feasibility assessment. And some of the things that research nurses have put into their feedback is actually, why do you need so many visits? People won't recruit if you're asking for this many visits. So really pushing back to the CIs to say, can you please justify actually why you need this many and why it can't happen at the GPs, or how do we do all of that? So some of it is just that whole feasibility, and sometimes people just want more because it's an opportunity and they think that research participants are a sort of an open book, as it were. But of course the other thing is absolutely those practical things like actually where are you doing these studies? So ICU follow-up studies, don't do them in hospital. People have got so many bad memories. You need to go to the place where actually people feel a bit safer, maybe where they can park for free. So thinking about the logistics of all of that, and actually how the timing of visits, all of those sorts of things. And the going out is great and wonderful if you can achieve that. But actually just paying up front, sending people, in Australia we used to send cab charge vouchers. You can, working out how you can prepay things, because as soon as people try and claim stuff back, it's a nightmare, isn't it? So I think the easier we can make it for people that doesn't actually overtly say, well, we know you can't really afford this, but just says, actually, you don't have to pay for anything. This is how we are going to account for this. Otherwise, we're never going to actually reach the people that we should be reaching.
Thank you. Do you think the mobile research units have a part to play in that?
Yeah, absolutely. And, things like, I know Southampton use paramedic cars, don't you? And all sorts of different ways of doing this. And doing it in ways that make it easy and acceptable for people. So working with the people you're trying to recruit to get from them, actually, what is it that will make the difference? So yeah, absolutely, those mobile units, as mobile as possible as well, because sometimes mobile just means you've picked it up and put it down over here, which, as we've heard earlier, that doesn't necessarily work. Mobile should mean mobile, not just here instead of here.
Lovely, thank you.
Okay.